Tumors of the stomach. It remains the third most frequent cause of worldwide cancer-related death. The mortality rate from gastric cancer in the US has dropped in men from 28 to 7.4 per 100,000 persons, and in women from 27 to 2.4. But still the reason is unclear. The risk for gastric cancer is greater among lower socioeconomic classes. The incidence is high still in Japan, China, and Ireland. The tumors of the stomach is comprised of majority is adenocarcinomas, which is 85%, and the remaining 15% is shared by lymphomas, leiomyosarcomas, and gastrointestinal stromal tumors. The two main types of gastric adenocarcinoma are diffuse type, in which there is absence of cell cohesion. That's why we cannot appreciate the tumor bulk, and the individual cancer cells infiltrate and thicken the gastric wall. And the other one is the intestinal type, wherein there is cohesive intestinal cells and there is gland-like tubular structures. The diffuse type usually seen among younger patients, and they occur throughout the stomach, including the cardia. And there is loss of distensibility of the lining of the stomach. Thus, it produces like a rigid appearance. We call it the linitis plastica or leather bottle appearance. It has a poor prognosis. The intestinal type produce ulcerative type of lesions, and they commonly appear in the antrum and lesser curvature. It is also associated with H. pylori. The long-term ingestion of high concentrations of nitrates found in dried, smoked, and salted foods appear to be associated with high risk. The nitrates are thought to be converted to carcinogenic nitrites by bacteria, and such bacteria may be introduced exogenously through the ingestion of partially decayed foods, which are consumed in abundance worldwide by the lower socioeconomic classes. H. pylori may also contribute to this effect by causing chronic inflammation, atrophic gastritis, loss of gastric acidity, and bacterial growth in the stomach. Several additional etiologic factors have been associated with gastric carcinoma. Gastric ulcers and adenomatous polyps have occasionally been linked, but data on the cause and effect relationship are unconvincing. Also, we have the Menetrier's disease and, of course, the genetic susceptibility of the patient. Gastric cancers, when are still small, they usually do not produce any symptoms. And as they grow, they produce a mild insidious onset of abdominal discomfort, early satiety, postprandial fullness, anorexia, nausea or vomiting, weight loss, and dysphagia. There may be no early physical signs. A palpable abdominal mass may indicate long-standing growth and predicts regional extension. And they can spread through direct extension from the gastric wall to perigastric tissues. They may involve the liver, the pancreas, and the colon. They can also spread via lymphatics and seed through the peritoneum. There can be a metastasis to intra-abdominal and supraclavicular lymph nodes, in which they are frequent. There can be an involvement of other areas like the metastatic nodule to the ovary, we call it the Krukenberg's tumor, Sister Mary Joseph nodule, which is the metastasis to the periumbilical region, and the Bloomer shelf. They are the metastasis to the peritoneal cul-de-sac. The diagnosis of gastric adenocarcinoma rests in the use of upper GI endoscopy or EGD, CT scan, and endoscopic ultrasound. Stages of stomach cancer. We have stage 0 up to stage 4, wherein the stage 0 involves only the mucosa. Stage 1 may involve the lamina propria or the submucosa. Stage 2, there will be invasion beyond this level, which lymph node may be affected or not. Stage 3, there is involvement of the serosa, and stage 4, beyond the serosa, and there will be a distant metastasis. For the treatment, complete surgical removal of the tumor with the resection of adjacent lymph nodes offer the only chance for cure. However, this is possible in less than a third of patients. We have a distal gastrectomy if the location of the tumor are distal, and for proximal tumors, we do total or near total gastrectomy. These tumors are radioresistant. That's why the role of radiotherapy is just for palliation for pain relief. Chemotherapy, we have cytotoxic drugs which appear to be beneficial in some patients, and we do also targeted molecular agents. The primary gastric lymphoma, they are relatively uncommon, and they represent 15% of less than 15% of gastric malignancies, and less than 2% of all lymphomas. And the stomach is the most frequent site of extranodal lymphoma. The primary feature of gastric lymphoma are epigastric pain, early satiety, generalized fatigue. There will be a thickened mucosal patterns with ulcerations on endoscopy. And the pathology may mimic adenocarcinoma. They are bulky, ulcerating lesions. Majority are of B cell in origin, and H. pylori increases the risk for lymphoma, especially MALT lymphoma. Treatment may be divided into medical or surgical. Medical if this is associated with MALT lymphoma, wherein there is a regression up to 75% if you are going to treat the H. pylori. So that is medical. While subtotal gastrectomy followed by chemotherapy in patients with primary gastric lymphoma. Chemotherapy can also be given among these patients.